Good afternoon, everybody. My name is Craig Coopersmith, and for a couple of more hours, I'm the president of the Society of Critical Care Medicine. And next to me,
Daniel Bakker, president of the European Society of Intensive Care Medicine.
And we are absolutely delighted, after a very long wait, to bring to you new definitions of sepsis and septic shock. Because we have a short period of time, we're going to get right into it. Our first speaker is going to be Cliff Deutschman.
Thank you, Craig, Danielle. Thank you, everybody, for joining us. A quick overview of what we will be talking about today. I am going to introduce the new definitions. This will be followed by the clinical criteria by Chris Seymour, clinical criteria for septic shock by Manu Shankar-Hari, and finally, my colleague Mervyn Singer, tidying up. So let's go straight to work. How, why, how, what? Why? These should be the banners for papers well known to everybody in this room. These are the original papers defining septic shock. The first, the result of a consensus conference in 1991. The second, a repeat conference in 2001. The papers came out slightly later. There has essentially been no approach to these definitions since the second consensus conference, so nigh on 15 years. What is emerged over time as a concern with these particular definitions is the first is that they are based on the systemic inflammatory response syndrome, about which there are some concerns regarding specificity. A new term, severe sepsis, was introduced as a result of these initial conferences. And again, different criteria have led to different and at times divergent results. In regard to SIRS sensitivities, these are two recent papers, both of them demonstrating that the use of SIRS is somewhat problematic. In the first paper, a fair number, I believe about 1 in 8 patients who were severely ill and clearly appeared to be septic were not identified by SIRS criteria. In the second paper, some concerns about the sensitivity. So, SIRS was raised to concern, and ultimately, what has become clear from basic science work is that SIRS is an appropriate response to infection, or for that matter, any other kind of inflammatory stimulus. Severe sepsis was a term that was introduced almost instantaneously. It generated some confusion, and it's not clear that confusion has ever quite gone away. Most people say sepsis when they mean severe sepsis. And it's never been completely clear that this new term, introduced in 1991, really was needed. Finally, different criteria, different results. Dr. Shankar-Hari will expand on this a little bit more, but these are, this is a study by Gajewski and others benchmarking the incidence and mortality of severe sepsis in the United States. This is 4 different ways to 4 different sets of criteria for identifying patients with septic shock, and they lead to very divergent results. In terms of incidence, anywhere between 1 million and 3 million. In terms of mortality, anywhere between 250,000 and somewhere in the neighborhood of 375,000. So again, you can see that simply by using different criteria to identify patients, the result is very divergent results. Indeed, when we look at the mortality from septic shock in different countries, and these are countries all with well-developed first world, if you will, health systems, a recent paper from Australia reported an incidence, a mortality of 22% from septic shock. A similar study that has not yet been published, but the data are well known, from Germany, indicated a mortality of 60%, and the Netherlands similar. So clearly, something about the way patients are being identified as having septic shock is yielding very, very different, identifying very different groups of patients. In fact, when we look at the variables that have been used to identify septic patients, severe septic patients, or patients with septic shock, we can see that there's a tremendous amount of variable in simple things like what constitutes hypotension, what constitutes adequate fluid resuscitation, what biochemical variables should be looked at, when should inotropes and vasopressors be used, and what constitutes organ dysfunction. Finally, the incidence, Studies in the basic science realm have markedly increased our understanding of sepsis pathobiology. And by pathobiology, we mean pathophysiology, biochemistry, immunology, all the different fields that have come to contribute to our understanding of what underlies sepsis. Clearly, we have come to learn that sepsis is more than just rampant inflammation, which is where we initially thought we were. There is a role for immunosuppression that's quite important. There's a contribution of non-immune mechanisms, for example, the endocrine system or the central nervous system. There is a possible adaptive nature of organ dysfunction. For example, vasodilatation in the face of inadequate delivery of some substrate to an organ or to a cell is clearly an adaptive response, even though it might result in a decrease in blood pressure. And finally, there has been a reappraisal of the nature of septic shock in light of increased understanding of organ dysfunction. So these are the reasons why we thought it was important to re-examine the definitions. The mechanism that was used was the SCCM, ESICM task force. The initial idea was, I believe, hatched in a conversation that involved 2 carbon fragments, myself, Andy Rhodes, and some other individuals to be fully disclosed. To fully disclose, it was probably Andy's idea in the first place. Some years later, we actually operationalized the process, put together this joint task force. The co-chairs, myself and Dr. Singer. These are the members of the task force. Most of them are well known to the people in the room. All of them have been substantial contributors to our understanding of all aspects of sepsis, some in the basic sciences, some in the epidemiology, some in running clinical trials, but all have contributed to the thought process over the course of quite a number of years. And here is the document. There are copies of the new documents available in boxes at either end at the far end of the stage. Don't all rush and grab them at once. They're a limited number, and they will be available in greater quantities later on. What? The task force deliberated for quite some time. It's 2 years since we first convened. Some things were relatively easy to arrive at consensus about. For example, we decided that it was beyond our purview to try to redefine infection. This was better left to experts in infectious diseases, experts in microbiology. We also clearly felt that sepsis is more than simply infection and 2 or more SIRS criteria. The host response to the invading organism was of key importance. And most importantly, sepsis represents bad infection, where bad means something leading to organ dysfunction. What this simply means is that the term severe sepsis is not helpful and is redundant with what most people think of when they think of sepsis, and therefore we felt it should be eliminated. The definition itself and arriving at the definition was probably the most problematic and contentious issue that we faced. Perhaps the most important point is that what we have always called definitions really aren't definitions. The dictionary says that a definition is a statement expressing the essential nature of something, or to be more succinct, a statement that describes what something is. And I would challenge anybody in this audience to tell me what sepsis is. In fact, I would welcome it. At this point, our understanding of the underlying pathobiology of sepsis is incomplete, and therefore coming up with a hard and fast provable definition is impossible. The best we can do is synthesize what is known about the pathobiology into a coherent statement that encompasses what we feel are the most important aspects of the septic process. So therefore, sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. There it is. There is your new definition. We've been hiding it for 2 years, but there it is. The problem, of course, is in these key distinctions. Organ dysfunction has now been incorporated into the definition of sepsis. We no longer have a need for severe sepsis. And so, therefore, the new sepsis is the old severe sepsis. And perhaps equally importantly, we focus now on a dysregulated host response to infection. The implication there being, of course, that there's something that is a regulated host response to infection. There's an adaptive, purposeful response, and then there is a response that potentially leads to harm. Of course, it's difficult at this point to even characterize completely that regulated host response, and therefore you can see why the issues with the definitions arise. Now, septic shock was a bit more problematic because there was some disagreement about what septic shock actually is. Is septic shock simply sepsis where the dysfunctional organ system is the cardiovascular system? The opinion of the task force was no, this was not the case. That shock, and particularly septic shock, involved abnormalities in cellular and metabolic responses that were a major contributor. What distinguishes septic shock from sepsis? Well, do you treat it differently? One would hope not. I think we all treat it with antibiotics and fluids, irrespective of whether we think the patient is in shock or not. If we believe they're septic, they get the mainstays of treatment. Is there a difference in the underlying pathobiology? Well, there might be, but we really can't answer that question at this time. So we're left sort of wondering is, what tangibly differentiates septic shock from sepsis? And the answer that we came up with was mortality. Very simply, septic shock is really bad sepsis. Septic shock is a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. There are some advantages to these new definitions that I think are fairly obvious. It incorporates the most up-to-date thinking on the pathobiology. It provides the closest approximation possible to describing at this point in time, based on what we know, what sepsis is. But there's some concerns as well. Frankly, both these new definitions are of very limited practical utility. They involve things that simply can't be defined. You know, what is organ dysfunction? What is a dysregulated host response? The most important aspect, I would say, of these particular disadvantages is that they provide new targets for investigation. We now have it is now incumbent upon us to identify what constitutes organ dysfunction with more precision than we have in the past, to delve into the mechanisms underlying the host response to determine what they are and how and when they might become dysregulated. But that leaves a need for something additional. Practitioners at the bedside need something to hang their hat on. There needs to be something that can help identify patients who are likely to be septic, patients with infection who are likely to get really sick. The preference of the task force was that whatever we came up with, and the approach was to replace SIRS, that it be data-driven. Again, almost all the things that we've dealt with in the past have not been driven by data. They have been a consensus of expert opinion. Very good expert opinion by very well-heeled experts, but expert opinion nonetheless. And therefore, we turn to our younger colleagues to come up with clinical criteria that would examine we asked them to examine existing criteria, and we also asked them to look and see if they could derive newer criteria, perhaps more applicable, and then validate them based on data analysis. And on that note, I thank you very much, and we'll pass on to the next speaker.
So we now have an intellectual framework, but I imagine everybody's wondering, what do I actually do at the bedside? And for that, we're going to head it over to Chris Seymour.
Thank you for the opportunity to speak, and I'd like to thank ESICM and SCCM for involving us in this process. As we begin, I'd first also acknowledge the contributors to the work that we'll go over. They're listed on this slide. They include epidemiologists, biostatisticians, clinical and basic researchers, as well as clinicians, all of whom really helped us along the way. So this is an accompanying document to the paper previously discussed by Dr. Deutschman that was released in JAMA this afternoon. So we started with what is sepsis and the new definition that was provided by Dr. Deutschman: a life-threatening organ dysfunction caused by a dysregulated host response to infection. But when thinking about clinical criteria, we propose that what we're really asking is, among patients with suspected infection, who is really sick? Okay, another way, if you think about all the patients that you encounter in the hospital in the white circle, there's a proportion of those in tan that have infection or suspected infection. And within that group, there's another smaller group that's really sick. And those are the ones that we conceive of as being septic. We did not search out new criteria for infection, nor were we planning to build an alert or sniffer among patients without infection. But rather, we started with a cohort of patients with suspected infection shown in the tan circle. That's the cohort. And then we investigated cases who were really sick. So we encountered some challenges, and I'm going to outline those one by one. The first is, what data are we going to use to answer the question? The second is, how are we going to identify infection in those data sources? What clinical criteria for sepsis are we going to study? And how are we going to define this really sick group? So this was the primary data cohort for the analysis. It's 1.3 million electronic health records at 12 hospitals in southwestern Pennsylvania. After typical exclusions, we had 150,000 patients with suspected infection in the ED, the ward, and the ICU. And we divided these into a derivation and a validation sample shown on this slide. We also, with the help of our collaborators, had additional data sets to validate some of our results. They include 20 hospitals from Kaiser in California, the national VA data set from University of Michigan and Jackawashna, the alerts cohort, which is a prospective cohort of hospital-acquired infection at Jena University in Germany, as well as pre-hospital records from King County EMS in Washington State. In total, the external data sets were more than 700,000 records at academic, community hospitals in a variety of regions, and including both community and hospital-acquired infections. So our next question was, how are we going to identify infection? And so I'll primarily focus on the electronic health record cohorts. We used the first episode of antibiotics and body fluid cultures in that patient encounter, and we excluded patients who received prophylactic antibiotics or those in the operating room. And then in an encounter, we determined when that infection episode occurred. Around that date and time, we then had a window of time to look for the clinical criteria that we were searching to study. And we started off with a 72-hour window and looked at a variety of others, even those as short as 6 hours around the onset of infection. Okay, so what existing clinical criteria were available for us to study? Well, we of course included the systemic inflammatory response syndrome criteria, but we also looked at the SCCM score, the sepsis-related organ failure assessment score, and the logistic organ dysfunction system score shown in this table. Okay, a quick reminder. Ideally, when it comes to identifying the really sick group, we would just get patients who are septic. But there is no gold standard for sepsis in the electronic health record. And rather, the really sick group is a proxy. This is an outcome that is likely to be more common among infected patients who are septic than those who are not. And of course, there's a variety of ways to identify really sick. We could have a clinical review committee that looks at individual charts and does a manual review. We could look at objective outcomes like death in the hospital, prolonged intensive care unit stay, or even billing or administrative codes to identify the really sick patients. But in the end, we chose death in the hospital and prolonged stay in the intensive care unit because these were objective outcomes that could be measured across the variety of data that we were studying. Here's a peek at what the patients look like in the primary cohort. Of the 150,000 with suspected infection, there was a small proportion who had bacteremia or confirmed blood cultures. There were typical demographics for patients in southwestern Pennsylvania, and the vast majority of patients had the onset of infection within 48 hours of arrival to the hospital. This was primarily community sepsis that we were studying. Patients were also distributed across the hospital, the ED, the ward, and 1 out of 10 had their onset of infection in the intensive care unit. So here's what some of the criteria look like, and there's a number of histograms shown on the slide. In the top are the ICU patients, and on the left is SIRS criteria, in the middle is SOFA scoring, and on the right is the logistic organ dysfunction system score. And the take-home message from this slide is that there's more organ dysfunction and higher SIRS among patients in the ICU than outside the ICU. But I'll also point out that these criteria are complex. The SOFA score has 24 points. They require laboratory tests that sometimes are not available in a timely manner. And we were motivated by the task force to think about new criteria that might be more timely and easier to use at the bedside. To this end, we studied 21 variables that were in Sepsis 2, or the 2001 document referred to by Dr. Deutschman, and used multivariable logistic regression for in-hospital mortality. And we developed what's called the qSOFA, or Quick SOFA score. This has 3 variables and ranges from 0 to 3, where a patient would get 1 point for elevated respiratory rate, a point for altermentation, or a point for low systolic blood pressure. So how did we assess the predictive validity, or how did we assess these criteria? What's shown here is a step plot where in the tan or gray squares is the area under the receiver operating characteristic curve for each of the criteria above a baseline risk for in-hospital mortality. And you can see that among these ICU patients, which is the panel that's on the screen now, that the SOFA and the LOD score had greater predictability for that outcome in the intensive care unit. Outside the ICU, we also found that SOFA and LODs performed well, but qSOFA was similar to these more complex measures. Okay, let's look at that another way. In this graph, we've taken all the patients with suspected infection and divided them into 10 groups. That's on the x-axis, where decile 1 to the left on the x-axis are young patients with few comorbidities who are quite healthy at baseline. Whereas on the right side of the plot, in decile 10, these are the sick patients with a lot of comorbid conditions that arrived to the hospital with suspected infection. Now, the circles are the odds ratio, also could be referred to as the fold change, comparing patients with greater than or equal to 2 criteria compared to patients with less than 2 criteria, where the black circles are SIRS, the green and tan are SOFA and LODs, and the red circle is qSOFA. I'd ask you to take home from this slide that across the entire range of underlying risk along the x-axis, that the SOFA and the LOD score had greater odds of a bad outcome compared to SIRS or qSOFA in the intensive care unit. Now, when we look at this same plot for patients outside the ICU, again, the complex measures do well, but you start to see that the red circles, or qSOFA, approximates the predictive validity and is quite similar, particularly at the patients on the right-hand side of the graph who are at higher risk at baseline. Okay, when we looked at qSOFA in our external data sets, we found that the predictive validity was very similar, and this, again, included patients with hospital-acquired infection, patients in the ward, the ICU, and even using the pre-hospital records from King County. There were a few other analyses requested by the task force. They asked us to look at different time windows around the onset of infection. Simple ways to measure altered mentation, here, Glasgow Coma Scale, anything other than 15. And also after multiple imputation for missing data. The results from these analyses were similar to our primary analysis. We also looked at the change in SOFA score, particularly an increase by 2 or more points from a pre-infection baseline, and found that that change in SOFA had a greater predictive validity than SIRS and was similar to a single measurement of SOFA alone. Okay, serum lactate. So lactate was not retained in the qSOFA model using a priori statistical thresholds. However, post hoc, we added back lactate to qSOFA at various thresholds to see whether it would improve our predictive validity. What we found is in this receiver operating characteristic curve is that there was little change when we added lactate to qSOFA, and in particular, very little differences in how patients were classified across the range of underlying risk. In these graphs, red is the model with qSOFA and lactate, tan or black are the results of qSOFA alone. Okay, so taken together, in the ICU, the SOFA and LODs have greater predictive validity than qSOFA or SIRS. But outside the ICU, the qSOFA score has similar predictive validity to the more complex scores. And these results motivated the task force to recommend clinical criteria for sepsis that are infection plus 2 or more SOFA points above baseline. and a prompt outside the ICU to consider sepsis was infection plus 2 or more qSOFA points. And with that, I thank you for your attention and point you to the website at the bottom of the screen for more details.
Thank you. We move on with the next presentation from Manu Shankar-Hari from London.
Thank you, Daniel. Good afternoon, all. Thank you for the opportunity to present the work that we did as part of the task force, and that's the paper in JAMA, which you can download later today. And thank the co-authors in the manuscript for their help in shaping the paper. So, septic shock, Septic shock, as we conceptualize today, comes from these two definitions from 1991 and 2001, which forms the illness concept by which we manage patients, diagnose patients at the bedside. Neither of these definitions provide a data-driven criteria to identify septic shock. And as Dr. Deutschman kind of spoke earlier about the fact that we now have a situation where the epidemiology of septic shock is clouded by the variability in criteria that are used to identify these patients and the relationship of these criteria to mortality. The second concept in the septic shock definitions is the concept of cellular stress, again highlighted by Dr. Deutschman. There are two things in cellular stress. First is the structural and functional alterations in cells, and the second aspect is the effect of cellular stress on the metabolic profile that happens in cells. So with that sort of background, we were tasked to do the septic shock definitions and the corresponding clinical criteria. So this is the definition of septic shock highlighted earlier. What I want you to focus on is the highlighted words, which is the circulatory and cellular and metabolic abnormalities and a greater risk of mortality than sepsis alone. These two elements of the new definition form the basis of analysis to arrive at the septic shock criteria. So how do we operationalize this definition at the bedside, i.e., how can we identify a bunch of variables that will explain all the attributes of the definition that we put forward? To do this, we did a broadly 3 set of work. First method that we used was a systematic review. Systematic review answered the simple question, what are the variables that are used in the published literature to identify and describe septic shock patients? And the reason for doing that was to inform the deliberations of the task force. The second method, which is probably the core of all the activity, is a Delphi process. The Delphi process involved 3 surveys within the task force members. The surveys were informed by the systematic review and the cohort studies, which I'm going to describe to you in a moment. And the goal here was to develop a definition, agree an analysis plan for the definition that we're going to put forward, and then agree the clinical criteria based on the analyses. So data analysis, we've got 2 sets of analyses. The first is a derivation cohort. The derivation cohort came from the Surviving Sepsis Campaign database. Involves 28,000 odd patients over 6 years, international cohort of patients. The validation cohort came from the same data set that Dr. Seymour highlighted earlier, which is the 12 hospitals from Pennsylvania, UPMC data set, and the 20 hospitals in the KPMC data set. I'm going to focus on the derivation cohort. You can see more details of the validation cohort in the manuscript. So to the results, first is the systematic review. The systematic review, we started off with approximately 1,000 odd articles, and 92 of those articles met our full text criteria. Out of these 92 articles, 44 of them present a septic shock mortality. The 92 articles were included in what I describe in the manuscript as a qualitative review. The goal here was to identify how are these definitions operationalized at the bedside, as in what variables were used by these studies to define septic shock patients. The quantitative review was used to understand the relationship between the criteria and the mortality. The slide is messy. That's deliberate to highlight the concept that the septic shock epidemiology is messy. So first and foremost is to kind of reiterate the fact that there are multiple criteria for the same problem. The second take-home message from the slide is the fourfold variation in mortality between studies, from 20% to 80-odd%. And the third concept is within each definitional element. Let's say hypotension was used by 10-odd studies to define septic shock. Within those 10 studies, there was extreme variability in the outcomes of septic shock. So in summary, there is heterogeneity in the way we operationalize septic shock at the bedside, and not all of these operationalization have all elements of the septic shock illness concept. So informed by the systematic review and the surveys that I described earlier, the Delphi process identified 3 variables, 2 to describe the circulatory dysfunction that you see in septic shock, which were hypotension and vasopressor needed to maintain mean arterial pressure. We deliberately chose not to describe fluid resuscitation or define it because that we felt fell outside the remit of our definitions. The second was the metabolic and cellular abnormalities. For that, the proxy that we chose was serum lactate. And the outcome that we chose to model the greater risk of death group that identifies septic shock was acute hospital mortality. So using the 3 variables, hypotension, vasopressor therapy, and serum lactate, you could define 6 groups of patients. Group 1 is a patient population that have vasopressor-dependent hypotension and a lactate that's greater than 2. Group 2 has vasopressor-dependent hypotension, but the lactate is less than or equal to 2. Group 3 is a population that has got hypotension after fluids, but the lactate is greater than 2. Group 4 is no longer hypotensive once you give fluid resuscitation, but they have raised lactate. This probably most closely matches the cryptic shock concept that's out there. And Group 5 is a population that is neither hypotensive at the time of presentation, but has got raised lactate. And final group is a patient who is hypotensive after resuscitation with normal lactate. The next question we asked is, how prevalent are these populations within the Surviving Sepsis Campaign database? As you can see, the most common subgroup of patients in the Surviving Sepsis Campaign database is Group 1. It's approximately 42.3%. And Group 2, which is the vasopressor-dependent hypotension with normal lactate, formed approximately 20%. Isolated hyperlactemia with or without fluid therapy formed the remainder of the population. The other groups, Group 3 and 6, are smaller subsets. So the next question was to understand what is the mortality of all of these subgroups of patients. So this graph essentially has got on the x-axis the different groups that I've just described to you. On the y-axis is the crude mortality. So Group 1 is a patient population that has got hyperlactatemia after resuscitation and vasopressor-dependent hypotension. This population has got a mortality of 42.3%. The next question that we asked is, how different is this mortality compared to the other subsets of patients? So we did statistical tests to compare the different groups, and what we observed was when you look at the crude mortality differences between these groups, Group 1 had a significantly different mortality profile to the other groups. Because it is a crude mortality or unadjusted mortality, we wanted to make sure that it holds true after risk adjustment. We developed 2 regression models, which is described in detail in the manuscript. The regression model, essentially adjusted for confounders, still showed that the Group 1 is a patient population that has got a distinct mortality profile even after adjusting for confounders, and all the p-values were less than 0.01. To kind of come back to the definitions wanted us to identify a patient population who had attributes of the definition, which is circulatory abnormalities and metabolic abnormalities, and the Group 1 has got vasopressor-dependent hypotension and raised lactate, which kind of matches all the attributes. The second aspect of the definition was to have a patient subset that is different mortality profile, and the Group 1 patient population has that. So based on those deliberations, the task force agreed that this group of patients possibly meet the criteria that represents the definition. One of the questions that kind of remains is, how did we choose greater than 2? We did 2 regression models, again described in detail in the manuscript. What we did was just to describe the graph to you, on the x-axis is the serum lactate concentration. On the y-axis is the adjusted odds ratio, risk-adjusted odds ratio using the regression model for acute hospital mortality. There are a couple of things in the graph that are interesting. First, you can see it's a nonlinear increase in odds ratio with increasing lactate. The knee of the change comes at around 2 millimoles per liter. And the odds ratio for that 2 millimole concentration of lactate was 1.4 with a confidence interval of 1.36 to 3.42. So that was one reason for choosing lactate greater than 2. The second reason was the task force wanted to identify the lactate cutoff with greatest sensitivity. So to do that, we did, again, a receiver-operator curve characteristics analysis, and I've shown the graph where you got sensitivity and the negative predictive value on the x-axis, the proportions on the y-axis. The graph, the orange bars represent lactate more than 2, green more than 3, and the blue bars more than 4. What you can see is a drop in sensitivity with increasing lactate concentration. And the lactate concentration of greater than 2 had a sensitivity of 82.3%. And this was therefore the second rationale for choosing lactate of greater than 2. So to summarize the clinical criteria that supports the definition that we put forward, despite adequate fluid resuscitation, if you got vasopressor-dependent hypotension and a lactate greater than 2 millimoles per liter, identifies the septic shock population that we believe represents the definition. And I'll leave you with the summary slide of the definitions. Thank you.
Thank you very much. It's my real pleasure to invite now to the podium Mervyn Singer, the European co-chair of this task force, to present indeed what are the controversies and concerns about the new definition.
Thank you very much, Daniel. Hi, good afternoon, ladies and gentlemen. Right. Let's go forwards, not backwards. What we did was, and I think it actually works out very well, we had what I call a soft launch. So we've been talking publicly for over a year, and that's allowed us to get some really, really useful feedback that's informed our thinking and also made sure we clarified the message. You know, there's obviously sometimes our fault in not perhaps sort of spelling out the message. Sometimes there's misinformation, disinformation. So we wanted to make sure our message is as crystal clear as we could get it. And that peer review, both informal and then formal. So we went to many, many societies, national, international, from developed and developing countries to get their feedback. And obviously in the peer review process for JAMA, also we got further feedback. And hopefully, in the last year or so, we've considered most, maybe all of the arguments. So our challenge to you is come up with, please, with an argument or a thought we haven't yet had thrown at us. And we've had lots of different questions, concerns raised, and these are just a number of them. And so what I'm going to try and do now is dispel some of these concerns, hopefully to the best of my ability. I'd like to, and I think we're all grateful to Howard Bouchner, the editor-in-chief of JAMA, for allowing us to infringe the word count in the manuscript, but importantly, he encouraged us to put this section into the paper so we can directly up front address the issues, our thinking, and our rationale for coming up with the suggestions we made. We wanted to be pragmatic. There is no absolute biomarker yet for either sepsis or septic shock. We wanted something that would be generalizable. We wanted to use identifiers that could be readily measured, that best capture what Clifford was describing earlier, this conceptualization of what we believe sepsis, septic shock to be. We wanted to offer these clinical criteria that would provide some objectivity, some reproducibility, so we all talk the same language. As Manu showed, there's this wide disparity at the moment. Hopefully this will standardize. And we wanted something that's easy to use. As Chris explained, the qSOFA is a tool, a prompt that can readily be done in a minute or so by the side of the patient. And the SCCM variables are either physiological or biochemical, but these are measures that should be routinely measured in any sick patient. Platelets, bilirubin, renal function, etc. So we're not discounting SIRS. Yes, it doesn't have a place in the sepsis definition, but still it's useful in helping a clinician, a practitioner, to think, could this patient be infected? Oh, their white count's high, they've got a high temperature, they may well be infected. But as Cliff explained earlier, SIRS just fits in with part of the appropriate host response to infection. It doesn't necessarily mean this dysregulated host response that can lead on to organ dysfunction. Sepsis is often diagnosed in retrospect, just like infection. We treat on suspicion, but a lot of the time, the patient turns out to have something else. Perhaps even up to half the cases that are originally thought to be infected turn out to be something else. Yet, we're still treating the patient on suspicion. And it's the same with sepsis. You start treating the patient in front of you. If they're ill, you start treating them. And clearly, as more data become available, you may modify your treatment accordingly. So therefore, identifying the patient as, oh, they are septic, by the SCCM criteria, shouldn't affect the way we're treating them, other than perhaps prompting or confirming that the patient in front of us is at high risk of a poor outcome. So what does qSOFA mean? It's a tool, as Chris showed you very elegantly, derived retrospectively on large, mainly US data sets. And he looked at different time windows before and after infection was first considered. So when cultures were taken, when antibiotics were commenced. And these were the patient population he sought. We don't know from these analyses whether or not the patients, and some of them, will have had long-established qSOFA point positivity. They may have had a head injury or a stroke, so they may already have altered mentation, for example. So we're encouraging prospective validation in different healthcare settings outside the US, in developing countries. So at the moment, we're suggesting that qSOFA be used to consider the possibility that the patient may have sepsis. And sepsis, the clinical characterization, is this rise in SOFA score of 2 points or more, concurrent with that new episode of infection. So if there's prospective confirmation in a whole variety of healthcare settings, then qSOFA may be a really useful, valuable, rapid diagnostic tool, particularly in countries where they don't have ready access to laboratory figures and data. Just to remind you, this is the SOFA score, 6 different criteria. And again, these criteria use clinical or biochemical markers that should be routinely measured in any patient you're worried about. So why did we use SOFA? Well, we're familiar with it, at least in the ICU setting. It does have predictive validity. It's been around for a long time. There are many studies showing that the higher the SOFA score, the more likely that patient is to die. It uses routinely measured variables, so we're not asking for anything special, and it can be measured by automated systems. The electronic data capture system in the ICU in which I work does it automatically day by day. It's not perfect. We don't claim it's perfect. It's not the final answer. But Sepsis 4, when that comes along, hopefully will improve upon it. So hopefully we're giving the impetus. This is an iterative process. What we're saying now with Sepsis 3 cannot be the final word. As our knowledge improves, as our ability, perhaps new diagnostics come through, then things will change. Perhaps we'll have a more robust system than SOFA. But as Chris mentioned, if you have an infection with a SOFA score of 2 or above, that gives you a 10% chance of dying in hospital. So these patients are at high risk. 1 in 10 of these patients will die. So it's a relatively modest SOFA score, but that translates to a high risk of dying. So clearly, we need to take these patients seriously. Let's move to the SOFA, and why did we want to change of 2 or more? So we recognize that many patients have comorbidities, either long-standing ones, chronic renal failure, for example, or they may have been admitted to hospital with a new problem, a head injury, a stroke. So they'll score SOFA points to begin with before the infection starts. But we will know the majority of these patients anyway. They've either had blood tests when they came into hospital or from their outpatient clinic visits or whatever. So most of these SOFA scorers will already be known. And so we're looking for a change of 2 or more from their pre-infection baseline. And if we don't know data, but they've come in previously healthy, then I think it's reasonable to assume a SOFA score of 0. So we don't have to do 2 tests to say, oh, it's a change. I think it's fair to make an assumption. Again, come back to this point of treating the patient in front of you. We're absolutely not suggesting that you shouldn't manage an infected patient until they hit the magic 2 qSOFA criteria or a change in SOFA of 2 or more. Absolutely not. So if you're worried about the infection, treat it. If they're oliguric, treat it. If they're hypoxemic, treat it. So please do not wait until the criteria are met. Let's move on to lactate. So what does hyperlactatemia mean? Well, it is a reasonable marker of cellular metabolic stress. It doesn't necessarily mean tissue hypoperfusion. There are other conditions, other situations that can push up the lactate. Liver failure, catecholamines, other drugs. However, lactate in a critical illness setting is an independent predictor of mortality, and it does reflect, as Manu was describing earlier, this cellular metabolic stress that we wanted to enshrine within the criteria for septic shock. So it's not in the qSOFA criteria. As Chris mentioned, it didn't add much to the predictive validity. It may have some utility in the intermediate group patients, but clearly more work needs to be done, especially prospectively. And again, we're absolutely not discouraging its use as a management tool. I use lactate, I'll still continue to use lactate. It has its limitations, but people who believe in it and want to use it, either as an indicator of severity, a guide to therapeutic response, please do so. All we're saying is, for the diagnosis of sepsis, it's not needed. We did, however, want to incorporate it into the septic shock diagnosis because, as I mentioned before, we want to reflect this combination of a cardiovascular circulatory dysfunction with the cellular metabolic stress, and lactate at present is the best readily available marker we have that fits this role of describing cellular metabolic abnormality. And as Manu showed you earlier, the combination of the two, hypotension, resistant to fluid, needing vasopressors to get the mean at 65 or above, gives you a much higher mortality than either hypotension alone or a raised lactate alone. And as you'll see here, if you don't have hypotension or a raised lactate, again, there's not that dissimilar an overall mortality. And this is looking at the surviving sepsis campaign database. Final few slides. What about children? We believe the definitions still hold true, but hands up, we lack the expertise to derive the clinical criteria that apply to children at different ages, from sort of neonates, babies, right through to adolescents. So we're pleased to say that pediatric initiatives are underway, and hopefully they'll have children and age-specific criteria that can inform or support, describe sepsis in children. In the developing world, again, we had lots of discussion about this. Many countries or hospitals within countries still lack the ability to measure lactate or even the basic biochemistry tests that go into measuring SOFA. As I mentioned before, we may be able to use qSOFA. Clearly, it needs prospective validation in these settings, But again, it may be a useful tool to pick out those infected patients at greater risk of doing badly. For septic shock, where you can't measure lactate, we're suggesting perhaps if you can't measure it, use a surrogate. There's some clinical data out there to support the use, for example, of delayed capillary refill. So again, we're hopefully providing some alternatives that people can use, although recognizing that now point-of-care testing is becoming more available and the price is coming down. So hopefully this sort of technology will spread worldwide. I know there's concern about coding, especially in the US, because reimbursement's a big issue. Thankfully, it hasn't crept over to the UK yet, but we tend to follow you a few years later, sadly. Oh, I can see it's resonating with you. What we're trying to do, because unfortunately to change an ICD code takes years, so it's not going to happen overnight. So we had the option of, well, do we wait until they change it, or do we say, look, here are the new definitions, these are what we're suggesting as the ICD codes that apply, please follow us. So it's, is it the organ grinder or the monkey or vice versa? We like to think we should be the organ grinders. So, as you've heard, you can download these papers now. The 3 papers are available. We've hopefully given you a digest, a summary of what we believe are useful changes that can be implemented. Yes, as I mentioned earlier, it's not the final word. We do need to go forward, and this will hopefully encourage more research, more discussion, and we expect lots and lots of discussion. Finally, I'd like to acknowledge the task force who are brilliant. We wanted healthy, lively debate. Nobody was destructive. It was all very constructive and very civil. And no bruises, none that show. I'd like to thank the leadership, past and present, of the European Society, the Society of Critical Care Medicine, who are brilliant, very, very supportive, and hats off to them. To Laurie Harmon and her staff at SCCM, who are brilliant in facilitating this. And finally, I think a big acknowledgement to Howard Bouchner and the JAMA staff, who were incredibly professional and very, very helpful, and we thank them as well. Thank you very much for listening.
So thank you to all our speakers. I'd like to make 3 different points. The first is the new definitions have been, in fact, now endorsed by over 30 medical societies worldwide. It's been endorsed by people from every continent that penguins don't live in. So every continent in the entire world, with the exception of Antarctica, has endorsed this. It's been endorsed by critical care organizations, by emergency medicine organizations, by infectious disease organizations, and by family practice organizations. We're very proud of that. The issue of JAMA, here, there's about 50 or 70 of them next to the stage on that side. There appear to be more than 50 to 70 of you in this room right now. Having said that, anybody who wants to come up, don't tackle each other or get along. Please come and get one. If you don't get one, they'll be available tomorrow in the exhibit hall at the JAMA Network booth. Finally, we understand that it's almost a certainty that 2 things are going to happen. One is people are going to want to ask questions, and we cannot ask questions in a room of 2,000. Number 2 is people are thinking, at least from the United States, but wait, there's different coding, there's CMS, SEP1, there's this. How does this all go together? Because of this, tomorrow at 3:15 in room 311, there's going to be hot topics and late-breaking science on sepsis redefined, where the people on this stage, plus Mitchell Levy, will talk about taking questions from the audience about everything that was just presented, and also how do we put together multiple definitions and make it an opportunity rather than a challenge. So on behalf of Daniel DeBacher, my good friend, and our friends in ESICM, and all the speakers, thank you very, very much.